Yeah, stream.
So where do you practice? Good afternoon. Good afternoon, everyone. Good afternoon, everyone. Hi. My name is Abby Kaler, and I'll be the moderator for today's session. I'm a nurse navigator working at MD Anderson, and I've been on the planning committee for putting together the COVID conference today. So today's session is going to be about metastatic breast cancer that has metastasized to the brain. It'll be led by Dr. Teja Patel and Kathy Harris, and it's going to be live streamed on combinghouston.org. Dr. Patel is a breast medical oncologist at Houston Methodist Cancer Center, and she works in the high-risk area working with genetic counselors to identify and counsel patients that are at high risk for breast cancer. And Kathy Harris was first diagnosed with breast cancer in 2008 and found in 2009 it had metastasized to her brain. Dr. Patel is going to present to us for about 20 to 30 minutes, and then Kathy Harris will talk for about 5 to 10, sharing her story, her experience, and her broad range of knowledge. Then after that, we'll be open to the audience for any questions.
Thank you so much. So those of you that met me at the last session, I'm Teja Patel. I'm a breast medical oncologist at Houston Methodist. So we're going to take a few minutes to talk about something that is sort of the elephant in the room, right? So once you have metastatic breast cancer, patients kind of think about brain metastasis, are worried about the brain metastasis, and usually people don't talk about it. So we'll talk a little bit about background, who gets brain metastasis, what are some of the symptoms, and some clinical recommendations, and what are some of the future directions that we're going towards. So, women with metastatic breast cancer are living longer, right? So this is one of the main reasons why we have an increase in brain metastasis, because we didn't have this problem a decade ago when women were just not living as long with metastatic breast cancer. So as you can see here, with each decade, there is a significant increase in survival of metastatic breast cancer, mostly because of the treatment advances. This kind of tells you that for every patient that are diagnosed at different stages, so if you have a localized stage, the risk of eventually having brain metastasis is very low, 2.5%. If you have regional, so this is your stage 3 patients, the risk is about 7.5%. And if you have stage 4 cancer, you have a much higher chance of having brain metastasis. You can see about 14%. So interestingly, only about 10 to 15% of metastatic breast cancer, if you look at them as a whole, will have known brain metastasis. And I have to specify known because up to additional
Much more
much more in small subgroup of patients, specifically patients that live longer with the metastatic breast cancer. The other is HER2 positive breast cancer. So we know that we covered this in the last talk, where breast cancer is not one disease. You have estrogen positive, HER2 positive, and triple negative breast cancers. In cancers that are HER2 positive, we have really good treatments for the patients that are living a lot longer. But the problem is the anti-HER2, the Herceptin, doesn't really cross the blood-brain barrier significantly. And so because of that, they are the ones that have sort of the highest incidence of breast cancer, followed closely by patients who have triple negative breast cancer. Doesn't mean patients with ER positives don't have it, it's just less likely than the other two types. Number of metastatic sites. So definitely the more areas of cancer a patient has, the higher chance of them also having a brain metastasis. But we are also finding more cancer. What do I mean by that? Well, we have better imaging tests compared to a couple of decades ago when people were just getting CAT scans and the CAT scans weren't as good. We now have 3 Tesla, 6 Tesla MRIs. And so we're actually finding even small, minute amount of cancer that we otherwise probably wouldn't have found. And we're also having a lower threshold for imaging, right? So a lot of times patients who enroll in clinical trials, they say MRI brain has to be negative before you enroll. Or if you come in with a headache or something neurological, then your oncologist would potentially have a lower threshold to do the MRI. So perhaps we are actually finding more cancer as well. So how a patient with brain metastasis does is dependent on 2 main things. One is their tumor subtypes. As we had talked about, HER2 positive, triple negative, or ER positive, that trend still continues. So if you have a brain metastasis in a patient that has a HER2 positive breast cancer, the prognosis is very different than if you have brain metastasis in somebody that has triple negative or ER positive. So that kind of matters. No 2 brain metastases are alike. And the performance status of the patient. So I don't know if you've ever heard. How many of you know what performance status is? A couple of people. Okay. So oncologists use performance status to gauge how the patients are doing at home, right? Because when you come to see the doctor, we're only seeing you sort of, for that half an hour when you're sitting in the chair. So if we want to know how functional are you, what can you do, a lot of times you may notice your oncologist asks you, how much time do you spend in bed? Do you spend 50% of your time in bed? Do you spend 100% of your time in bed? How much time, what is the most activity you do in a day? So in patients that have brain metastasis, if you have a patient that, is otherwise doing fine, spending 100% of their time, during the day outside of the bed, they're going to do better than if you have a patient that is not doing that. Patients who are spending 75% of the time, or patients that are bed bound. So it actually matters what functional status they come in with. So I alluded to this earlier, but there is something called blood-brain barrier. Okay, what that means is that there is a tight layer of endothelial cells which essentially acts as a barrier to a lot of drugs or systemic therapies. The reason we have this is because we want to protect our brain from infections, and so that's why the blood-brain barrier exists. But unfortunately, because of this, a lot of our treatments can't cross the blood-brain barrier, and brain becomes what we call a sanctuary site. Okay, what that means is even though you could potentially eradicate cancer everywhere else, then it's possible that there's no cancer here because the treatments work really well. Sometimes in the future, you can have cancer appear just in the brain because that's the area that the cancer sometimes could be hiding. Okay, but once you have this brain metastasis, so once you have the cancer in the brain, then we think that there is some leaky vasculature and the blood-brain barrier is not as effective. But before that, that is a hindrance. So we call it seeding, the sanctuary site. So when does it occur? When does this breast, cancer cells potentially feed to the brain? Well, it could potentially happen during the initial diagnosis or first recurrences, and as we said, that could be sort of maybe sanctuary site. And then it can also happen, moving forward. So different types of cancers have different ways they present. So for example, in patients that have HER2 positive breast cancer, generally, it's over here where seeding kind of happens as you go along, and patients with triple negative patients, it happens a little bit sooner. So how do patients present? So on the left, it doesn't actually say it, but majority, 50% of the patients actually present with non-specific symptoms of nausea, okay? So, if you're on chemotherapy or if you're on treatment, you have nausea with it anyways, how do you tell the difference? Well, the nausea you have with the brain metastasis is persistent. It doesn't, normally you can take a Zofran and it gets better, but, this nausea is kind of persistent and it's not getting better. It doesn't matter if it's right after treatment and right before treatment, it continues to persist. So anytime you have sort of this nausea that won't go away, flag and that needs to be evaluated further. The next one thing is 35% of the patients present with headaches. Okay? Headaches are fairly common amongst all of us. We all get headaches from time to time. So not all headaches are concerning. So it's mostly all of these symptoms are persistent. And generally, we would say that if you have a headache that you've never had before, and you have a headache that won't go away, if you have a headache that's every single day, well, that's concerning. If you have headache once, is that concerning? No. So please don't go home today, and if you have a headache, you're like, oh my God, I went to this talk and this is why it's happened. No, it's a headache, it's persistent, or at least, coming every 1 week to 2 weeks, that's the one that I would be concerned about, and the one that maybe has something else associated with it. The next presenting is about 22%, so about a fourth of the patients actually present like as if they've had a stroke, right? Hemiparesis, meaning that they feel like their arm is not working or their leg is not working, it's weaker than the other, they can't walk without stumbling, things like that. So those are good reasons to call it off. About 13% of patients have some visual changes where they feel like they, can't see one side of it, or have had problems seeing, vision, like they have double vision, they have blurry vision, like that. And about 12% of patients actually have seizures. And so either the family witnesses or they have a seizure, and generally in those situations, they present to the emergency room and then have further evaluation. The next photo right here is a scan, and you can kind of see this is sort of a specialized scan looking at the cancer itself, and you can see that the cancer itself is kind of bright here, and you see the dark areas, the black areas all around, that's the swelling. So what happens is you have a limited space in the brain, and the concern is not only the cancer itself, but a lot of times, anytime you have a foreign body, you have a lot of inflammation all around it. So you have a lot of swelling here, and what that does is it causes a lot of pressure. So imagine, a very tight space that you're kind of expanding something, something's got to give, right? So the normal tissue gets kind of swept aside, and then that's when patients start having these symptoms of, all the symptoms that we kind of talked about. So, the question that I get asked all the time is, should we screen patients with MRIs? So there are some cancers, like lung cancer, specifically small cell lung cancer, that if you are diagnosed with it, they get MRIs, okay, at diagnosis. But we don't do that in breast cancer. In fact, we will not scan patients, with a brain MRI unless they're having symptoms or unless we need it for clinical trials. And so why don't we? So, of course, the pros of scanning the patients is you reduce the risk of them presenting later with symptoms, right? Like I'm telling you that all the symptoms, the headache, the nausea, the paralysis. Perhaps if we screen them, then patients wouldn't have to go through it. There's an increase in likelihood that you could do smaller local measures because hopefully you'll find cancer sooner. And then hopefully you can be enrolled in clinical trials where something different or new could be offered to you. But the cons of screening, before actually, symptoms present, is we really have no direct evidence that this would be beneficial. Because there are side effects of brain treatment as well, right? So meaning that, as I mentioned, about 15% of patients with brain metastases, are found after they've passed, and there was no indication that there was something going on in the brain. So now, if we start screening everyone without symptoms, we'll find those, and then we'll do treatments for them, and everything has a side effect. The question is, do we really need to do that? Sometimes this is getting better, but if we find brain metastases in patients, sometimes some clinical trials for the rest of the body will exclude them, or will say that it has to be stable for 4 weeks, or it has to, enough time has to pass before we would enroll them. So again, that kind of potentially limits the other treatments as well. And sometimes, believe it or not, there is such a thing called false positive, meaning that we do a scan and we think maybe there's something there, and then we have to continue to monitor it over time. And this is time and expense for the patient as well. So once you have a diagnosis of brain metastasis, it makes sense to follow it. But if you have no diagnosis of brain metastasis, you have no symptoms of it, traditionally we don't have enough data to pursue it. It doesn't mean it shouldn't be looked at. It's something that we should look at it in a clinical trials format, but it's not something we should do routinely. So once you have diagnosis of brain mets, what are some of the treatment options? Well, the very first thing is supportive treatment, okay? As I mentioned, the general symptoms are because there's swelling on it or parts of the brain are being kind of squished. So steroids generally work very well for inflammation or swelling, so that's the first thing that we give. If there are seizures, then we talk about treatments for seizures or treatment for any other neurological dysfunction, whatever they come in with. That's sort of first and foremost. Now, surgery, brain surgery to be particular, is part of our treatment options, okay? When would you consider surgery? Well, the very first thing is that it's surgically accessible, right? You only can remove something if it's somewhere where you can get to it without damaging a lot of normal brain, okay? In general, if there is a one mass or one dominant mass, which means that generally we look at tumor that's at least 3 centimeters or more, those are in general oftentimes surgically excised. Not in every case, but in a lot of the cases, if you have a patient that comes in and has a 5 centimeter mass in the brain, surgeons will be involved to discuss, okay, does this need to be removed or not? And so if a patient comes in with, let's say, 5 different masses, but only one is 5 centimeters, we would still talk about potentially removing just that one that is larger. So it's important to make sure that it's removed. Now, sometimes you need the surgery for diagnosis. So we recently had a case of a patient that had breast cancer and lung cancer. Okay, we were treating both at the same time. Unfortunately, she presented to the hospital with a seizure and was found to have brain metastasis. I'm a breast medical oncologist, and I felt that this was a lung cancer metastasis. Of course, as you can imagine, the thoracic oncologist is like, no, this is from breast cancer. So we actually had to take her to surgery to prove that I was right, that it was from lung cancer. So sometimes that happens, okay? And oftentimes this is not something we have to look for. I mean, if you have a patient with breast cancer who has multiple metastases, they teach us in medical school, don't look for zebras. If you have somebody with multiple breast cancers, it is going to be breast cancer. But, if you don't have that, sometimes you need further evaluation. We'll talk a little bit about radiation, but what if that area was already radiated? In that case, the only way to remove the area or help it is to do resection. And then the other thing is emergent removal. So sometimes, if you have a very large mass that's causing some shift and causing, a patient to not be able to move the arm or the leg, well, that's a medical emergency, right? We don't have a lot of those emergencies, but in those cases, they go to surgery so that they can relieve the pressure as soon as possible. Nothing else relieves the pressures as much as fast as surgery. So those are some of the indications for it. And maybe I should move it bigger. So, I like these tables because it allows you to see what are the benefits and what are the drawbacks. So the benefits of surgery is there have been studies that show that if you actually have a patient that has at least 3 months to live. So, everything is balanced. If a patient has at least 3 months to live, if you remove a brain metastasis, that is going to help them live longer. Right? Because removal of the brain metastasis in clinical studies is shown to be superior than just doing radiation in the whole brain. Okay? Now, we'll talk a little bit more about this in a minute because there's other options as well, but definitely surgery becomes an important tool if you have a large cancer. And of course, again, increased functional independence, so meaning that if there is somebody, if you want to relieve pressure, if you want them to improve right away, surgery will do that. Now, there are some drawbacks, right? So if the patient has cancer everywhere else, if you do brain surgery, you can't give them chemotherapy the next day. You need to wait at least 2 weeks to 4 weeks, depending on what kind of recovery there is. So you have to kind of balance it out that, if there is a large area of cancer in the liver, can that wait 2 to 4 weeks to get chemotherapy while we actually wait for the brain to improve? So you have to kind of balance it out. And of course, there's risk for operations. Any surgery has risk as well. So you want to balance that out as well. means is that if a patient comes in and has multiple metastases, generally more than 5, so you have 5 1 centimeter areas of cancer all around. Even though they're small, the problem is you can't really do surgery in 5 different areas of the brain. And so how can you get to it? Okay, so whole brain radiation is essentially exactly what it sounds like. They radiate essentially the entire component of the brain to treat all, not just the 5 areas of metastasis, but any other microscopic deposits that perhaps we did not see. And definitely, if you can imagine, unlike surgery that just resects the area right here, if you do whole brain radiation, it just radiates the whole brain, it definitely decreases the risk of cancer in parts that does not have cancer, right? I mean, because you're kind of sterilizing the whole brain. But it definitely decreases the risk because of neurological deaths, because it will stop patients from having another cancer or reduce the risk of having another cancer in the brain. Won't stop, but reduce the risk. But as we'll talk about in a little bit, it doesn't actually improve survival, okay? Meaning that, let's say we radiate an area here, okay? And if something were to happen here, we can radiate that area there, okay? So because we are able to treat multiple brain metastases as it happens, doing a whole brain radiation now doesn't actually help patients live longer. So of course, the benefits of doing whole brain radiation is less risk of having recurrence, decreasing in neurological deaths, and if you have multiple lesions, really that's the best way to get to all of them. But drawbacks are, unfortunately, in 2018, when we radiate the whole brain, there are some cognitive impairments, meaning that patients' memory is affected, patients' neurological well-being is affected. And so there's multiple clinical studies that are looking to see if we can back off on it, but it can affect patients' mood, patients' memory, a lot of the things that we want to preserve as they actually are living longer. And again, as I said, there's no improvement in overall survival. So whether you do whole brain radiation or you do spot treatment, patients, again, there's no difference in survival. Whole brain radiation also causes fatigue and hair loss, as well as, again, it's 2 to 3 weeks of Monday to Friday treatment. And so it can also cause chemotherapy delay. This, radiation can cause fatigue, so it may be that even though the radiation may be 2 weeks, it may take another week or 2 weeks to recover. So we're talking about, again, delay or systemic therapy, chemotherapy. And so kind of keep that in mind. But as I said, there's clinical trials right now of, doing whole brain radiation, but sparing something called the hippocampal area. This is in research right now, it's not standard of care, but hippocampal area helps with memory and the functions, as we had talked about, and it's radiating that area that causes all the problems. And so the research is showing whether if you don't radiate that, if the patients would actually do better. There's also concurrent medications. So, for Alzheimer's, there's all these drugs that potentially help with the memory. So what if we give it at the same time, we can potentially potentiate and improve some of the memory function at the same time the radiation is being given. So that's actually under active research as well as maybe giving smaller doses of radiation. Perhaps maybe they don't all need, because a lot of what we do is standard, right? I'm sure you guys have seen when you go to the oncologist, the chemotherapy doses are usually based on height and weight. The radiation is just like a flat dose. Everybody gets the same. Perhaps maybe smaller doses may be indicated. But again, it has to be studied in the clinical trial setting. So what is in between? So radiosurgery has emerged as sort of an in-between. Okay. So what happens is, as you can see here, you have multiple X-ray beams attacking one target. Okay. So tumor is destroyed without significant damage to surrounding tissues, and essentially you deliver a much higher dose of radiation to the selected target. So it's essentially, they call it radiosurgery because you're basically frying one part of the mass and leaving all the other parts kind of intact. The beams have an accuracy within 1 millimeter. So this is a very accurate thing. So it's not that it's left up to chance. Generally, it's done, it can be done in one fraction, or it's 3 to 5 fractions, so it's not 2 weeks, but it's 3 to 5 treatments. And you probably have heard, I didn't write down all the names, but gamma knife or proton beam, there's a lot of different names for this as well. You do have to wear a mask because for it to get within 1 inch of it, the face can't move, so there is a mask involved. But generally, if you use radiosurgery when there's a deeper location, remember I told you that sometimes we do surgery if it's accessible. So we've had cases where we would have done surgery, but it's at an area which is just not accessible, but we don't want to radiate the whole brain. So we go ahead and do this radiosurgery. When the tumor is less than 3 centimeters, as we talked about, if it's more than 3 centimeters, we would want to do consider surgery. If there's no diagnosis, we don't actually have to go after it. Mild or no symptoms. But if the patient is very symptomatic, we have to consider surgery or something else. But if the patient's not having a lot of symptoms, then this can be used. And fewer lesions. So as I mentioned, that kind of is a key. So if you have multiple areas, we really don't like to do radiosurgery at 10 areas. So we don't do that. If you have multiple areas, then at that point, the patient is better served with doing the whole brain radiation. And of course, if there's contraindications to surgery, if you have somebody that because of heart reason or because of whatever reason, we don't think that they're going to live more than 3 months, or maybe they're bedbound, maybe surgery would actually harm them, then we could consider radiosurgery as well. So of course, the benefits are that it's shorter, quick recovery time, less chemotherapy delay. And then the drawbacks are, again, it doesn't, just like surgery, it doesn't prevent recurrence in other parts of the brain, as we have talked about. And sometimes you may require multiple repeat sessions. So the American Society of Radiation Oncology guidelines actually says, again, that the whole brain radiation can help, as you said, with recurrence of brain metastasis, but it does not improve overall survival. And you could do this radiosurgery if you have, again, less than 3 brain metastases. Now, there's a clinical trial that's ongoing that is studying more, so 5 up to 10 actually, brain metastases. But again, it's not standard of care. So it's a very paradigm shift, even in this situation where before, this is a case of a 53-year-old that had completed a breast cancer treatment 2.5 years ago and now presented with 3 small brain metastases. So traditionally, what we would have done is we would have said, okay, because you have 3 metastases, we'll do whole brain radiation. But now we would do just, those 3 spot treatments, and then we would follow her. If there's going to be new metastases, again, we would do spot treatments and follow and so on and so forth. And then at some point, if necessary, a whole brain is part of, an accepted treatment. So at some point, we could potentially use that as well. So as you can see, I'm a medical oncologist, but I spent a lot of time talking about surgery and radiation because when you have brain metastasis, a lot of times we talk about local treatment first. We got to figure this out first. But that doesn't mean that there are no systemic treatments. It's just that we don't actually have systemic treatments currently that are approved for brain metastasis. So if you have somebody that has brain metastasis, there is no treatment that they have to be on. They have to have radiation. Perhaps they have to have surgery, but there is no systemic treatment that they have to have. Unfortunately, the research for that is still lagging. It's something that, again, we're gearing up to study more about, but we don't have enough data. Generally, we continue the same treatment if up here to down here, if the cancer is under control, and we can, treat the brain metastasis separately, then we continue to watch the patient with the same treatment. But there are treatments that potentially cross this blood-brain barrier, as we had talked about. And treatments don't really have to cross the blood-brain barrier to actually get to the brain, as we talked about. Once you have brain metastases, we think that the vasculature gets a little bit leaky. So I wanted to just show you that currently there are a number of drugs that are in clinical trials depending on if it is a HER2 positive breast cancer. And as we had talked about, they have sort of the highest incidence of brain metastasis, just because they do live longer in the HER2 treatment, so the cross the blood-brain barrier. But there are other studies in sort of all tumor types as well. So we definitely have a lot of ongoing research. And there's not a particular drug that I can go over because, again, it's a very heterogeneous group of patients and a number of clinical trials. But I think it's exciting that at any given time we have this many brain metastasis studies. I'm only going to spend a couple of slides and talk about something called leptomeningeal carcinomatosis. So this is something different than brain metastasis. So brain metastasis is when you actually have a parenchymal, like a brain mass, okay? What leptomeningeal carcinomatosis is, it's actually in the fluid. So, just like we have blood that flows into our veins and arteries, in the brain, we have something called CSF, cerebrospinal fluid, okay? When you hear of a kid getting meningitis, it's actually inflammation or infection of this CSF. And this is very important because the same CSF goes around your brain, and it goes down your spine, and it's actually just keeping all of that healthy. If you actually have cancer in the CSF, it's actually very, very concerning. And it actually this is more serious than just having the brain metastasis. Okay? And as you can see here, sometimes you can have cancer cells that clog the blood vessels. So you can have increase in pressure because the CSF is not able to leave. Sometimes you can have neurological dysfunction. And sometimes when the blood vessels get occluded, you can also have things like strokes because, again, you're not moving things along as you need to. Now, again, primary treatment is treating the patient's neurological symptoms, steroids, as we had talked about. If there's any bulky area of this, so if you can see on an MRI that this area has the most cancer that's occluding the blood vessels, then we could use radiation in those spot areas as well. And as we had talked about, because our treatments are not as active as we want in the brain, in this situation, we actually give treatment in the fluid that bathes the brain. Okay? Now, not everybody gets the treatment. In a patient that is otherwise functional, a patient that is otherwise has good quality of life, is the one that you either offer the treatment either by doing lumbar puncture or putting a port in the brain called Omaya. How many of you have heard of Omaya? Yeah. So again, it is for instance, very selected group of patients. For breast cancer, we're more likely to do this than lung cancer or other cancers because we do have some treatment options that we know are active. But again, the amount of research in this is still ongoing. And because this happens, unfortunately, in not as many patients, I would say 1 to 3% of patients, we don't have large clinical trials to guide us, but we do have smaller clinical trials that give us some active drugs to use in this situation. So future directions, to have a collaborative, multi-center niche trial. So right now what's happening is, we get so excited about, metastatic cancer, triple negative, HER2 positive, ER positive, that this small subgroup of brain metastasis as a unique entity is not being recognized until recently. So a lot of the drugs that I told you are active in patients with brain metastasis, we didn't study them specifically for it. What happened was when we were studying them in general for metastatic disease, we ended up seeing that, for brain metastasis, perhaps it works well. But now, in the last 5 years, or decade actually, we're actually having studies simply for patients with brain metastasis so that we can actually study the actual drug in depth. And then again, expanded use of the stereotactic radiation for patients with more than 3 to 5 brain mets. And then, of course, using targeted therapies. So some of the targeted therapies that we have that are oral can penetrate the blood-brain barrier. We do see some responses. We're actually studying them to see if we can make it an active therapy. And that's it. Thank you very much. Now I can make yours. Dr. Kell said my name. My name is Kathy Harris. That was a lovely welcome and really thank you so many flashbacks. I was first diagnosed in 2008, in January 2008, with stage 3, hormone negative, HER2 positive breast cancer. Went through the normal treatment, surgery, chemotherapy, Herceptin, radiation. Took about a year and finished that up. Buttoned up, tried to move on with life like we're all supposed to do. And then in June of 2009, we discovered a single metastasis to my brain. And so we treated it with gamma knife. And it was luckily a very successful or a positive reaction to gamma knife radiation. I can answer any questions on that treatment if you guys have it. I always tell people that it's not the worst thing that happened to me in MD Anderson. It wasn't super fun, but it wasn't super awful either. It's very doable. Then after we finished my gamma knife treatment, my doctor really didn't know what to do with me. I think this mentioned that there was not historically a lot of research for brain metastasis. And so I was sort of a data set one. And so we asked around, and all the HER2 experts even couldn't agree what to do with me. So I was young and had small children, so we decided to get as aggressive as possible. And so I started taking Tykerb and Xeloda, which is oral chemotherapy. And I started that in August 2009, and it took a little while for us to kind of tweak what my dosage needed to be to keep my side effects manageable. And ever since we got my dosage right, I've pretty much been able to stay on that drug without progression. I'm actually NED, that's exciting, but ever since then. And so we've just been kind of rocking along. And so I was thinking about my remarks today. I could go on and on about my story. If you guys have any questions, I'm happy to answer it. But I remember the day that I found out that I had a metastasis in my brain. And just prior to that, I had a conversation with my oncologist, and I told him, I said, Dr. Reeser, I can handle anything. I can handle anything. For some reason, I thought that lungs and liver and bones weren't all that important relative to my brain. I was like, if it's in my brain, it's going to really freak me out. I can't do it. And for some reason, that seems so different to me, which is crazy, right? Because we need our lungs too, right? But the brain just seemed different and scary to me. And when I found out that's what had happened, that was my other shoe that dropped. We all wait for the second shoe to drop, and that was mine. And I was terrified because I had never heard of anybody with a brain that didn't have terrible experiences and terrible outcomes. And so I think from an advocacy perspective, I try to just say, yeah, there are people that can be treated and they're still walking around. I'm still driving carpool. I've gotten to watch my kids grow up. Some days better than others, just kidding. But so I didn't have that hope when I got my diagnosis because I knew, just knew bad stuff. So I'm here from one perspective to say, yeah, it can be good. And then the second was, I remember feeling very different on that day when I became net static. It's like I needed a new playbook. Everything was really different than just my first series of treatments. You're treated, you're done. You get to go away from the hospital, you check back every now and again, whatever your doctors tell you to do. But this was really different for me. All of a sudden, services that didn't matter to me mattered now. And my whole playbook was different. And I think that's what I love about conferences like this and different efforts that we're really putting an emphasis on metastatic disease because it is different. And I think that is a message from an advocacy perspective that I try to tell people that things change. It's the second shoe's dropped, more shoes might drop, you don't know. So anyways, that's all I had, really, just got me questions. I could go on and on and on. So.
Kathy, you didn't say what your presenting symptoms were.
You don't hear me if I just talk.
Is it?
It's kind of funny. One of the drugs I took was Herceptin, and as
one of the side effects from Herceptin can be decreased heart function. So I went to the doctor not feeling right, and I just felt kind of weird, and I thought I wanted an EKG. And then I complained to him that during that I had a weird headache too, and I'd never had a brain MRI, so he literally had his his hand on the doorknob, and he said, you know what, let's get you a brain MRI. And I'm like, really? Do I need one? He goes, I think so. Let's just do it. And so it turns out I never got my heart tested. I guess it was fine. And the headache that I had was unrelated to my tumor. So I have no idea how it all worked out.
I don't need it. So I'm just wondering, you just had the one tumor and you got gamma, and in all this time, no other ones ever appeared?
Yeah, I'm weird. So
Cool.
I wish everybody could be as weird as me, but
I'm weird also.
and it's interesting because my doctor really struggled with what to do when we weren't treating the tumor anymore, because we removed the tumor with the gamma knife, and then it was like, well, what do we do now? And we went with the medication route because I was terrified, first of all. I was like, I needed to do something. And I wanted, I was relatively healthy and felt fine. But he's like, I don't have a tumor to treat, so we don't have anything to watch. So it's a really strange data set, I guess.
A follow-up question to that, and since you're an outlier, in a good way,
Yeah.
What is your surveillance now going forward?
So I still, my radiation oncologist still checks in with me because he tried to get rid of me, and I told him no. So I see him once a year, and then I go see my oncologist. I think it's every 3 to 4 months. I check in with him. He does some blood work. At first, I did brain MRI. So right after the procedure, I had brain MRI. Then 6 weeks later, I had a brain MRI, and we did that for a while. Then they stretched it out over time. And I had to get comfortable with it too. I was super nervous. I'm like, no, we have to. But then after a few years of that, the neurologist released me too. So I haven't seen him unless it becomes symptomatic. Now I will tell you, if I get symptomatic and something gets wacky, I'm in an issue. But one thing that was important for me was I'm an engineer. And so I had to establish my rules of the road with my oncologist, like what headaches. I think you referenced it. What headaches do you want to hear about? Because I had the brain metastasis, every headache I had, they were giving me an MRI, which was not necessary. So he gave me rules that worked for me. So I would encourage anybody, with anything, when do you want me to call you? What aching pain is important? Like for me, it's like he gave me rules about my headaches because I was having tension headaches, and I would be nervous because of this headache. And it would just escalate. So he would kind of give me rules that got me comfortable, that I didn't have to get an MRI every time I had a headache, which was, I got to where I memorized the pattern of the balance.
Does anyone else have any other questions? And do we have any questions online?
How was your experience with insurance companies throughout that?
I'm glad I haven't. They never questioned any of the treatments that my medical team was for. I have heard, in the various online forums that sometimes the gamma knife isn't, it's questioned, but in my case it wasn't. Surgery wasn't really an option for me because of where my tumor was located. Again, memory lane. But so I haven't had any. I have found a lot of the drug companies, there are different programs I've been able to get on to help with one of my medications, and some of them are need-based and so on. So after a long time, I've finally figured out the tricks.
I'm curious with that. Is there any connection between getting a brain metastasis and getting a metastasis in another organ? I'm thinking particularly of the lung.
Yeah. So if you have I guess the opposite is more true. So if you have more lung or liver metastasis, if the number goes up, the chances of having brain metastasis goes up as well. But we can, have cases where you have brain metastasis, but not longer liver. So in general, we're taught that there's patterns of spread, okay? But sometimes cancer doesn't read the book. And so sometimes we can have cancer that does its own thing as well. So
Yeah, because mine are going to the lung first and then to the brain.
yes, so yeah, I mean, generally speaking, the pattern is that it goes to lung or liver and then goes to the brain. But we also have these patients that it goes to the brain first, or it goes to the brain and then other places. But as I said, there's no statistical, I can't tell you that if you have lung metastasis, we have that little statistics that we talked about, that if you have stage 4 disease, you have, 15% chance of having brain metastasis. If you are HER2 positive, it's more, but not specifically lung or liver. There's no data.
You described your relationship with your doctor. It sounds like there's some communication going on there. What questions other patients to ask their doctors in this situation? I think it's really important. What you said, you struck me with this doctor described certain patterns for headaches. I think there's important things to ask our doctors.
So when I had my brain metastasis, so what I used to do before I would go see him, which I think is so normal the more I talk to other patients, is that I would try to diagnose myself before I would tell him. I didn't want to bother him with my existence. And so when I first was diagnosed, I sat down with him and I just said, I'm telling you every little thing that hurts me, and then you can tell me what, like one time I think he told me breast cancer doesn't go below the elbows and knees. Is that true? I think I kind of remember that, but I'm like, my fingers hurt me. He doesn't need to know that. So he started to kind of give me rules to kind of get me under control because I was wacky. But I just kind of would ask him when it came to the headaches, I needed him to tell me, or my rules is if it doesn't get better in 2 days, if it's getting worse, not better, if you feel nauseous, we had kind of. If I could go in and take medication and it would respond to medication, it was probably tension. And so we kind of worked through it together. I would talk to him about what was ailing me, and he would so I would recommend not self-diagnose, because one time I told him, I was having such and such a problem, and I called my friend. He's like, I need you to call me. And he gave me his email address. He's like, I'm your doctor, not your friend. So I don't know if that answered your question, but it's just an open dialogue. Don't be afraid that you seem weak or whiny if you're telling them what hurts. If they don't know, they can't. And then they can tell you, I had a problem in my hip. And they're like, congratulations, it's early onset arthritis. But at least I know.
Yeah, and it's easy to say, I think for as an oncologist, I tell them patients that it's easy for us to reassure, or we can pick out things that concern us, and so it is important for us to do that.
That's one thing I would like to second what Kathy's saying about having that strong relationship with your doctor, because I help monitor forums for women, going through different types of symptoms and things like that for cancer, and I shudder because they're asking each other's opinions, and it's like, these are the kinds of questions you should be asking your doctor and your nurse. And we've got apps that connect us to our doctors, and you get it, in response within 12 hours. And like you had his personal email address. I was able to find my doctor's direct line, just Googling long enough. But it's just so important to have that strong relationship. And then if you can't develop that with your doctor, then definitely go get another opinion. Find someone that's going to guide you and be there, because we're all different. And then you start to get overwhelmed by what's happening to everybody else, but that's not you.
Well, I think another thing that, like you said, we're all different. So when I'm working, I volunteer in the clinic at MD Anderson. So when I'm talking with patients, I always tell them, as they start chemotherapy, for example, it's like, if you're experiencing nausea, and it's whatever medicine your doctor is giving you isn't working. I was like, tell your doctor. There are 8 different kinds they can try, and what worked for your buddy in the chair next to you isn't going to work for you. But they don't know that you shouldn't suffer, or you shouldn't be afraid to talk to them about it. But that's a side.
I think we have time for one more question. Anyone? Well, thank you, Kathy and Dr. Patel. This was a wonderful discussion. Thank you.
Here's my doctor, Susan.
Yeah.
That's what Dr. Fraser said.